Hello and good afternoon, good evening, depending on where you live here in the United States. I am Tamara Tobias. I am a nurse practitioner at Seattle Reproductive Medicine, and I'm so excited to have this first webinar that we have today to talk about female dietary patterns. This idea, having this webinar was brought because of the Ohio Reproductive Society had some funds that they actually donated to NPG. And because of those funds donating to us, we were able to provide a $1,000 grant to those who want to tell us about their projects that they're working on. So those going into nurse practitioner or midwife or PA, whatever it is that project, we want to hear about it. And we are providing $1,000 for a grant for you to share your information, and that you will be able to take with you to attend the ASRM annual meeting. And so this is going to be our first webinar, and I'm going to turn it over to our NPG chair, Marty Gephardt, who is going to introduce our first speaker. So Marty.
Okay, thank you, Tamara, and thank you all for being with us today. We have several members from the NPG board with us, and then several of you who have logged on to hear this presentation. I am Marty Gephardt. I'm the chair of the NPG board, and we are very excited to have Elizabeth Sanderman with us today and presenting her research with us. So I'm going to go ahead and start with the introduction to her so that we can turn it over to her and see what she has to share with us today. So Elizabeth is a nurse practitioner student completing her studies at Boston College. Her background includes nursing and public health research. She moved to the Boston area relatively recently after living in Australia for many years. While there, she had 2 children through IVF. She earned her master's degree in public health and worked with a team of researchers conducting a clinical trial of acupuncture during IVF treatment. She's currently an infertility support group facilitator and is passionate about providing evidence-based, unbiased information to anyone experiencing infertility. Today, she is presenting a systematic review of studies on female dietary patterns and the outcomes of IVF. This review was conducted along with Dr. Lauren Wise and Sydney Willis, 2 reproductive epidemiologists from Boston University's School of Public Health. And with that, Elizabeth, I would like to turn the screen over to you and you share with us. Thank you.
Hi, thank you so much for being here. I'm super excited to be here. I just need to take 1 second to, there we go. Can everyone hear or see my slides right now?
Elizabeth, can you put on the presenter mode? It's up at the top. Just switch it over to presenter mode.
Okay, let me see if I can do that. Hold on 1 second.
Yep. I think it's under display settings.
Okay, would it be on my computer?
Yeah, when you go to share screen, exactly the screen you were on up at the top, you would just click on it. There's 2 different modes up at the top. It's just switching them, just so we don't see your coming slides or your.
Yeah. Okay, sorry. We actually worked this out before this started, but I think I've maybe switched things around a little bit. Okay, no, so what are you seeing right now?
Nothing just yet. You unshared.
Oh, gotcha. Okay.
Yep.
Okay, so let me see here. Okay, I'm going to start from this.
That works. Perfect.
Okay, is it still just my slides?
It's perfect.
Awesome. Okay, sorry everybody, technical difficulties. Okay, so hi, thank you so much for being here today. Thank you to the ASRM NPG for organizing this and giving me the opportunity to share this literature review on female dietary patterns and IVF outcomes. So why I care about this topic? Studies suggest that fertility may be declining worldwide. Diet accounts for nearly 1/10 of the global burden of disease, and some epidemiological studies link diet to reproductive outcomes. So it makes sense to ask if diet impacts underlying fertility. Along the same lines, IVF treatment is one of the most successful treatments for infertility. However, IVF treatment only has modest success rates and can be fairly burdensome to patients. Diet is potentially modifiable, and so it makes sense to ask if diet can improve treatment outcomes. When I started this review, I quickly realized that this literature is really challenging to understand. So I'm going to present an overview of the topic, talk about findings from the Mediterranean diet and how these studies are different from one another. Then I'll talk about other dietary patterns and go over some methodological concerns from all the studies and end with some conclusions. So there are a few different ways that diet might impact fertility. Diet may elicit weight gain or loss, and some studies have linked weight gain and loss to fertility. Diet may also promote the healthy development and function of the reproductive system, and some studies have linked diet with the development of reproductive conditions such as fibroids and endometriosis, which can impact fertility. Diet may also impact the processes involved in reproduction or infertility treatment and elicit some kind of immediate effect on those processes. So what a person eats can be thought of in a few different ways as well. At the most specific level, diet can be thought of in terms of the micronutrients that are ingested, such as omega-3 fatty acids or folate. The next level up is dietary components or macronutrients, such as dairy, meat, and fish. And the most holistic approach to diet is looking at dietary patterns, which take into account all the different dietary components that a person is eating over a period of time. And some examples of these patterns are the Mediterranean diet, the keto diet, and the DASH diet. There are a couple of different major study types that have been used so far to study diet and fertility. The first is large longitudinal studies, such as a nurse's health study. In this type of study, large groups of women are followed over many years, and the reproductive outcomes are examined in relationship to what they were eating. In time to pregnancy studies, women are followed from the time they start trying to become pregnant to see if there are differences in the time it takes to become pregnant based on what they ate. And the last group of studies follows women undergoing IVF treatment to see if their treatment outcomes differ depending on their diet. So as you can see, micronutrients and dietary components have been studied across all the different study types. However, the bulk of what we know about dietary patterns comes from studies on women undergoing IVF treatment. So when conducting an IVF study, choosing the outcome to use can be challenging because there are so many that can be observed. The outcomes outside the pink box are sometimes referred to as intermediate or surrogate outcomes. And this is because it cannot always be linked directly to pregnancy or live birth. And for this reason, many researchers prefer to use at least one of the outcomes in the box because it is easier to directly translate these to patient recommendations. So in this review, we wanted to examine the evidence linking dietary patterns to fertility, which led us to focus on studies conducted in women undergoing IVF treatment. We excluded studies that focused on how diet might elicit weight loss or weight gain during treatment, and only included studies that included biochemical pregnancy, or live birth as an outcome. These studies may have also included an intermediate outcome, but they had to include at least one of those three. So our initial search of 4 databases resulted in about 5,000 studies. And after removing duplicates and other studies that did not meet our inclusion criteria, we ended up with 9 studies total. We did an initial quality assessment of these 9 studies and removed 2. The first was a study by Ferns et al. In 2015, which was removed because the reporting article didn't really contain enough details on the methods for us to fully assess the quality. And the Jahangir-Farr study was removed because the results section contains a major error, and it's reported throughout the manuscript. And we tried to contact the authors, but we weren't able to contact them. So we ended up with 7 studies total. Within our group of 7 studies, there were 9 different dietary patterns that were investigated. The Mediterranean diet, the Alternative Healthy Eating Index, or the AHEI 2010, a fertility diet, a Profertility Diet, a rice and miso soup diet, a vegetable and seafood diet, a Western diet, a preconception diet, and a health conscious diet. And I'll talk a little bit more about what these actually mean further along. So lucky for me, because I'm pretty new at deconstructing this sort of literature, all the included studies had basically the same design. They were all observational prospective cohort studies. And what this means is that in the studies, women were presented to an infertility center and were recruited and enrolled in the study at some point. Data on their diet was collected at baseline, and then they were followed for 1, 2, or a number of cycles. Women in each study were grouped according to their adherence to the diet being studied, and then their outcomes were compared to see if women who adhered higher to a dietary pattern did better, worse, or the same as women with lower adherence levels. I'm going to start by talking about the findings from the Mediterranean diet because this was the most commonly investigated dietary pattern. So the Mediterranean diet is basically a diet that involves a high intake of fish, legumes, whole grains, fruits and vegetables, a moderate intake of alcohol, and a low intake of meat and dairy. For the outcome of biochemical pregnancy, 1 out of 4 studies found an association between higher adherence to the Mediterranean diet and biochemical pregnancy. It's important to note, though, about the study that the exposure or the diet under study was actually an average of the couple's dietary adherence score. So they took the man's score and the woman's score, added them together and divided by 2. And that's how they got their diet score. So you don't really know how much the woman's diet contributed to this association. And none of the other 3 studies found an association. So 2 out of 4 studies found an association between higher adherence to the Mediterranean diet and clinical pregnancy. In one of these studies, there was a strong association. However, the association was only present in women under the age of 35. And in the other study, it was only present in women over the age of 35. In the study where there was an association in women who were older, it was only found when comparing the lowest level of adherence to the next to lowest level of adherence. The authors of the study stated that this finding was likely spurious, which, if true, would bring us back to just 1 out of 4 studies with an association. So for live birth, 2 out of 3 studies found an association between higher adherence to the Mediterranean diet and live birth. In one study by Gaskins and colleagues, the positive association was only found when examining the lowest level of adherence versus the next to lowest of adherence level, and it wasn't present for the 2 higher adherence levels. So the results are kind of all over the place. And I think when the results are kind of like this, it's fair to ask if you can actually even compare the studies, like maybe there's differences across the studies that make them incomparable. So we took a good look at what some of those differences might be and if there were differences, and we found that there were a ton of differences between these studies. I'm going to talk about 3 of the ones that really stood out for us, but there's like a lot more. So the first thing that we noticed was that the Mediterranean diet was defined really differently in different studies. So the diet is basically thought of, like I said before, as a high intake of fish, legumes, whole grains, fruits and vegetables, a moderate intake of alcohol, and low intake of meat and dairy. In this chart, the pink box outlines components that were part of every working definition of the diet. However, everything outside the box was different. And some of these differences may really matter. For example, moderate intake of alcohol, which could be up to 2 glasses of wine a day in some studies, and whole grains were inconsistently included. And both of these components are considered essential components of the Mediterranean diet, and both have been independently associated with reproductive outcomes, both positively and negatively. So it may matter that the studies weren't actually talking about the exact same thing. Studies were also different in how long they followed women for. In 3 studies, women were followed for 1 fresh embryo transfer, and the other 2 women were either followed for 1 egg retrieval and all resulting embryos, or many embryo transfers resulting from different oocyte retrievals. It's probably unlikely that the results for 1 fresh embryo transfer can accurately predict what will happen for a person over the course of an entire embryo cohort or multiple retrievals, so some caution may be necessary when comparing studies with these different endpoints. Lastly, there may be differences in study populations in terms of the spread of adherence to the Mediterranean diet. As I mentioned earlier, women were put into categories of adherence based on their dietary intake compared with other women in the same study. However, it's not really clear how much these different categories compare across studies. For instance, the Cariana study was conducted in Greece, where adherence to the med diet may be quite high or more varied than what it would be like in the Soon study conducted in China. But because the studies only contain like these internal comparison groups, we can't really know how much group 1 from the Cariana study really compares to group 1 from the Soon study. So it could be like comparing sort of apples and oranges. So with that, I'm going to leave the studies from the Mediterranean diet behind and move on to the other dietary patterns. So one thing I really want to emphasize is that each of these dietary patterns that I'm going to talk about now has only been studied in one study ever. So the evidence for any of these patterns is very minimal. So I'm sorry about like the busyness of this slide, but I wasn't sure how else to present this. So the first dietary pattern is the Profertility Diet. The Profertility Diet is based on the EARTH study, and the EARTH study first investigated associations between individual food groups and IVF outcomes and around 357 women, and then took the results, designed a diet based on the results, and then tested the diet in the same basic cohort of women. The Profertility Diet is comprised of a high intake of supplemental folic acid, vitamin B12, vitamin D, low pesticide fruit and vegetables, whole grains, seafood, dairy, and soy foods, and a lower intake of high pesticide fruit and vegetables. There was a strong linear association with biochemical pregnancy, and live birth in this single small study. The AHEI 2010 is a diet designed to prevent chronic disease, and the Fertility Diet is a diet designed to prevent anovulatory infertility. Neither of these diets was associated with biochemical pregnancy, or live birth, and these were also investigated within the EARTH study. The health-conscious, low-processed dietary pattern appears to be negatively associated with biochemical pregnancy, so women who adhered higher to this diet did worse. This diet contains a high intake of fruits, vegetables, whole grains, fish, and legumes, but low intake of mayonnaise, snacks, and meat products. This is the same study that took an average of the couple's diet scores, so it's not clear whose diet matters the most within this score. A Dutch preconception diet was also associated with higher clinical pregnancy rates in a small single study. This diet is comprised of adequate daily intake of whole grains, vegetables, and fruits, weekly intake of at least 3 servings of meat or meat replacers, and 1 serving of fish, and use of monounsaturated or polyunsaturated oils. The rest of the dietary patterns are pretty much what they sound like. The Western diet is sort of like a fast food type diet. Vegetable and seafood diet is vegetable and seafood. The rice and miso soup diet is rice and miso soup, and they were not associated with IVF outcomes. So there are a couple of issues related to the methods used in all the studies in this review that I want to talk about because there is a potential for bias to be introduced by these methods. I hope it's not going to get too nerdy, and I apologize if it does. So in studies on nutrition, one of the greatest challenges is collecting accurate data on what people are eating. Many studies use food frequency questionnaires, which basically ask what women ate and how often they ate it during a period of time. It's very important that these questionnaires are tested for their accuracy in the population being studied because they have been shown to perform pretty differently in different groups of people. While some studies used a validated questionnaire, no study used a questionnaire that had been validated in women undergoing IVF treatment or experiencing infertility. Some questionnaires had not been validated in women, and some had not been validated at all. So basically, there's some potential in every study that women's diets were not accurately captured. And for anyone who's an epi nerd out there, this could lead to misclassification of the exposure. However, because participants did not know their outcomes when they provided diet information, this would likely be a non-differential attenuating association towards the null. Sorry. The second major methodological issue is the potential for selection bias. So as I showed you before, women were recruited after presenting to an infertility center, and information on their diet was collected at some point, usually close to egg retrieval or embryo transfer. What is a concern with this type of design is the potential for some people to be missing from the sample who should have been there. So I'm sorry this slide is sort of all over the place, but I wanted to try to present this visually. So moving from the left to the right, everyone who might be in your sample starts trying to become pregnant. Then at 6 to 12 months, everyone who is not pregnant becomes eligible for infertility treatment. At this point, some people will seek treatment and some people will not. And those that will not or do not will not be in your sample. Moving along, some people will become pregnant either before their initial evaluation at an infertility center or before they can enroll in your study. So those people will also not be in your sample because they've become pregnant and they've left. Many studies also collected diet information at oocyte retrieval or embryo transfer. And some people will not have oocytes to retrieve or embryos to transfer. So these people will also not be in your sample. So you end up with a cohort with some missing people. The cohort you really want is everyone eligible for treatment. However, the cohort you actually get is everyone eligible for treatment, minus people who never sought treatment, minus people who became pregnant before they can enroll or provide information about their diet, and minus people who did not provide diet info because they had no oocytes or embryos. So you end up with this kind of like middle ground sample in terms of fertility. You're missing your most fertile people, anyone who became pregnant before entering the study, and the least fertile people, anyone with no oocytes to retrieve or embryos to transfer. And the problem with this is that if the diet you are interested in actually increases fertility or decreases fertility, you would be less likely to see this in your sample because you've kind of gotten rid of your extremes. So again, for any nerds out there, when you lose your most fertile people, that could be a bias from left truncation. Then when you lose out on your least fertile people in this type of a design, you come up with a survival bias. That's probably too much information, so I'm just going to move on. So the third issue is potential for confounding. So as I said before, all the studies in this review were observational. And one essential part of conducting this type of study is controlling for confounding. Confounding is basically when there is another factor that is causing your results besides the one you're interested in. So you want to control for any of these factors in your analysis. In studies on diet and IVF, there can be so many factors that might lead to confounding, and this chart just shows some of them. Across the studies, only 3 potential confounders were controlled for across all the studies: maternal age, BMI, and smoking. Other variables that may be a concern for confounding, such as duration of infertility, physical activity, weight loss or gain, use of complementary and alternative medicine, and paternal factors were not universally controlled for. So we don't really know if it was the diet or maybe some of these other factors that caused the results. The last thing I'm going to talk about is reverse causation, which is a sneaky sort of confounder. So participants don't live in a bubble. Women can find a lot of information about diet and fertility on the internet and books and in other sources. This is concerning for observational studies because it is possible that women who have been trying to become pregnant unsuccessfully for longer may be more likely to adhere higher to certain diets they believe will enhance their fertility. They also may be more likely to continue to struggle to become pregnant because they have a longer duration of infertility coming into the study. This in turn can make it appear that adhering higher to some diets results in having more difficulty becoming pregnant. So unfortunately, the way studies on this topic have been designed so far, investigators do not know at recruitment how long participants have been trying to become pregnant when they're enrolled in the study. And they don't know if they're aware of information on diet and fertility and if they changed their diet in response prior to entering the study. So this could potentially result in things looking the opposite of what they might actually be, if that makes sense, resulting in reverse causation. So some takeaways from the literature reviewed. Studies suggest that higher adherence to a Mediterranean diet, a Dutch preconception diet, and a pro-fertility diet may be associated with improved outcomes after IVF. However, findings from studies on the Mediterranean diet are inconsistent and difficult to compare. A Dutch preconception and a pro-fertility diet have only been studied in a single small study each. All studies contain potential sources of bias like misclassification, left truncation, survival bias, and confounding. And future studies with rigorous and more unified methodologies are needed. So there's some other broader considerations that I'll just run through really quickly. It's important to note that there's no information on what would happen if a woman changed her diet today in terms of her upcoming cycles. Women were asked about their intake in the 6 to 12 months before they were enrolled in the study, and we don't know any information at all on what would happen if you changed your diet, because they could have been adhering to that diet for quite a long time. The outcomes are also a little reductive. It's possible that eating a certain way has benefits not measured by pregnancy rates or live birth rates, like maybe there's enhanced wellness or enhanced ability to cope with treatment. So it may be a little bit too reductive to just have it down to those two, or just to have it down to the outcomes of pregnancy, live birth, or any of the surrogate intermediate outcomes as well. And lastly, there may be some risks or consequences for overly optimistic diet recommendations. The diet recommendations are probably benign. However, it's also possible that women may blame themselves or the way they ate if their cycle fails or something like that. So there may be some reasons to exercise caution around any of the findings around diet until there's a lot of certainty, but I'm definitely open to other perspectives on that. So in conclusion, currently there is not strong evidence to support recommending any single dietary pattern for the sole purpose of improving pregnancy or live birth rates in women undergoing IVF treatment. Thank you.
That was excellent, Elizabeth.
Thanks.
I was just typing in the chat box here, and this is Marty Gephardt talking again, that, you know, patients are so desperate to be involved in their care and to do whatever they can do on their end to be successful, that, you know, dietary modifications, even if we don't have great literature to prove one way or another, even just from the mental aspect that, you know, you're doing everything that you feel like you can do, even with failure, you know, the patients can feel better about closing a chapter saying, well, I didn't leave anything out there that I didn't try. You know, I did do all the modifications that I felt were, you know, going to improve my outcomes. So, I mean, I work with patients all the time that are, you know, asking what more can I do? And we go over diet all the time, and they're 100%, you know, like, yes, let me do whatever I can do.
Yeah, no, I definitely hear that. I think there's like a lot of power in doing these things. So I don't know how I stand on it, because yeah, I think there's a lot of power in having something to do. And there is some evidence that it might help. So I think that there's definitely an argument for saying something about it, because who knows, maybe in future studies it will be shown to be strong. And a lot of the things I talked about would actually make the results seem less pronounced. So if studies were done better, it's possible that the results would be more dramatic. So yeah, it's hard because you don't want to like discourage something that might actually be useful, but then you don't want to encourage something with someone, you give someone the idea that this is gonna, you know, really make them a massive impact when you don't know for sure. So I think it's really challenging,
right,
to know what to do.
I think particularly with the Mediterranean diet, I mean, there's so much solid evidence about the health benefits of certain diets, including Mediterranean and the DASH diet and whatnot. I don't know as much about these pro-fertility diets, but some of these other more mainstream diets have just general health benefits. And from a preconception standpoint, like regardless of whether, you know, maybe there's a placebo effect in terms of, you know, patients are feeling empowered, that it's helping them with their journey, but hopefully they'll become pregnant. And just the very, very idea of optimal nutrition from a preconception standpoint has benefits. And I think we have to not lose sight of the long game with our patients, whether, you know, they get pregnant on this cycle or the next cycle, but just kind of adopting a healthy diet in general is going to have good longer term effects for themselves and epigenetically for their offspring. So
yeah, I totally agree with you. That's a really great point. The thing that's weird about the Mediterranean diet is that the alcohol component's in there. So it makes it really tricky, because obviously you don't want to be recommending it. So it's very tricky because it's in all the studies. It's like up to 2 glasses a day. So
you can modify Mediterranean.
Yeah, but then it hasn't been studied at all, because the ones that have been studied include that. So it's very strange. Mm-hmm. So yeah, it was an interesting group of studies.
Yeah. Megan, can I ask why you give Benadryl, or what? I'm assuming you're not recommending the Benadryl. Is it the patients that are taking the Benadryl?
No, Dr. Berg actually came up with it, but there's no studies. He does go over it, saying like there's no studies to show this makes a difference. But just with inflammation, again, he thinks reducing inflammation. But they're obviously very tired. They usually start it with their FET cycles with progesterone, and then they take it to heartbeat or discharge 3 times a day, 25 milligrams.
Wow.
That's a lot of Benadryl.
Yeah, they do say they usually get you pretty used to it, and those are usually the patients like he's just throwing everything at them, gluten-free, dairy-free, as well. So for a while he was doing an elimination diet, which was really hard for the patients. And we work with nutritionists to help them with that. But that he's kind of gotten away from. He's still with the gluten dairy free, and a lot of our doctors actually have started following with the gluten and dairy free.
As a general rule, or just with the more complicated?
More complicated, or failed euploid embryos. I know if they have 2 failed transfers, they'll try that to see. We've actually had some good success. We had a patient who the very first patient he did it on, she was actually going to be using a gestational carrier. I think she had 6 or 7 failed transfers, was waiting for a carrier. And he's like, just humor me, do gluten and dairy free. And she got pregnant the first month she was on gluten and dairy free. So I think that's kind of what swayed him several years ago, but we've been doing it for a while now, but no studies.
That's really interesting, going at it from an inflammation standpoint, really.
Mm-hmm. Yes, and he's Dr. Berg is certified in functional medicine, so he's kind of been, he likes the more natural. So it's been interesting. A lot of supplements as well he does. So
I'm taking a functional medicine health coaching class right now, so I'm keeping.
Yes.
They and I are speaking the same language.
Yeah.
If I could ask Elizabeth a question, and thanks again, Elizabeth, really enjoyed your presentation and all your hard work. And I may have missed it, but I'm just curious, because I know you had something like 5,000 articles you started to delve into. Is there any evidence at all, and maybe you said this, just on women in general that become general without IVF, that any of these diets work for them? I mean, you were focusing, it sounded like, right, specifically on women undergoing IVF, but I'm just curious, taking a step back, since it sounds like what you find was you found some conflicting evidence, maybe the Mediterranean diet, but you're really not sure. So I was just curious, is there any strong evidence about the more general population of women becoming pregnant related to any of these diets?
Yeah, so that's a really good question. So just looking, taking out the weight loss and weight gain piece, which is a whole other body of literature, there is one study that was like a case control study done in Spain in the general population. And then actually Sydney Willis is doing a look at this across 3 different databases. So there's really just that one. So, so it's just not, it hasn't been really, there are studies on sort of macronutrients and micronutrients within the general population, but not dietary patterns. Thank you.
Elizabeth, I thought this was so great, and I was just a little bit surprised, I guess, when you were pulling up all the different diets, that there's a pro-fertility diet out there and there's a preconception diet out there, but they don't include legumes. And they're so high in fiber, they're high in iron, they're high in folate, magnesium, all the things that you want women preconception wise to be utilizing. And it's prominent in the Mediterranean diet. So I'm just curious what you thought about that. Oh, you're muted.
I don't know why that got left out. That's such a good question. Because that study, the pro-fertility diet and the fertility diet, those 2 that you're talking about, I think those were the 2 that you're talking about. They also looked at the Mediterranean diet and they did include legumes in that. So I don't know. It's a good question. It's curious as to why it's not there, isn't it?
That they're just so nutrient rich, and that we would think we'd want our patients to include.
All I can think is maybe their population didn't eat a whole lot of legumes. They didn't really have enough, like they had enough to sort of include. I actually don't know why they wouldn't have included it. a question for Jorge Chavarro and his colleagues, if you know who he is. So he did the Earth study. So anyway, I think they're out of Harvard. So definitely a good question. I think he's done a lot of studies on supplements. So yeah.
That was another question I had, is supplements, but it looks like those were all over the board too. It was hard to.
Yeah, so I'll have to see if I can flip back here on the confounders. So some people, everyone included some kind of multivitamin or supplement as a confounder, but no diet really had anything specific except for the Profertility Diet, which has vitamin D and B12 in it. But otherwise, they didn't have anything specific around, supplements. I used it to see if there's some confounding from it. So, yeah.
Almost everybody is deficient in vitamin D these days.
Yeah.
It's becoming a chronic problem, I've been hearing. So that was probably not a bad ad.
Seattle, we just have everybody at it.
Yeah, same here.
That is Seattle.
If it's okay, if I could ask another question.
Yeah.
Yes, Elizabeth, because as an NPG board member, we're just starting this process. So I'm curious, do you have any questions for us? Or also, I'm curious about like your next step, where you're thinking your career would go. So I guess I really have two questions for you.
Oh.
And also, if you could just maybe briefly tell us what you're thinking of doing with this work and how it relates to the next step in your career. That's all right.
This actually was just like a weird obsession. I think it was like my coronavirus obsession or something.
Okay.
So I don't really know. I just really I had a personalized support group who was following, actually like several people who are following diets. And I just really wanted to know what the evidence was. So yeah, it just became like a total obsession, like a really nerdy one.
Great, good for you.
I guess
wonderful.
I don't know if it's healthy or not, but it definitely helped me like get through some hard times. So anyway, so I'm graduating at some point. I've done my didactic part of the program I'm in, and then just finishing the clinical part, and I don't really know what's next. So I think it's just been sort of like, get through coronavirus and somehow finish my clinicals and then figure it out from there. So yeah.
Elizabeth, I can tell you what's next.
Okay.
You're going to become a member of our board.
Okay.
Well, and also,
it's a great lead-in segment for, we do have most of our board on here today. And one thing we are interested in is growing our board members, and our involvement of all of the NPG members to be involved in what we do. And, being able to do this and this little presentation and offering it for other nurses and nurse practitioners to listen in or look at later as it's going to be recorded is great. So at the end of this topic, if nobody has any other questions specific to your review, I'd like to just open it up to, I think we have a few other people on here that aren't board members. If anybody has a question to us about how to get involved or what we do, because again, we're looking to grow our members and grow our board, and just want y'all to have access to us and know that we're approachable. And
yeah. Well, I will ask one last thing of Elizabeth, and then I love talking about how people can get involved with the NPG always, because I know I've recruited Elizabeth into some work, and so I'm excited about that. But so Elizabeth, I'm going to put my academic hat on, and the fact I mentor a tremendous number of students, and I also mentor a lot of faculty, and I'll say, this is tremendous work. I know doing these kind of systematic reviews is so much painstaking work to get through the literature and do your extraction and do all this wonderful presentation of the various related articles. And so my question to you is, what are you doing with this topic in terms of publication?
Oh, yeah, thank you for asking that. Yeah, so it's actually in revisions right now. So
Great.
yeah.
So it is already en route. Good. That's
It
good.
is. Yeah. I just found out recently. So yeah.
It's in revisions. Congratulations.
Thank you. It felt like a major thing. So we're trying to publish it in an open access journal. So it should be readable for lots of people.
Excellent.
Yeah.
Congratulations.
Thanks for the question.
Sure. So Marty, do we want to, maybe for those who are not on the board, maybe the board should introduce themselves? Would that be helpful?
Sure. Yeah.
We have a pretty small group. Maybe we can all introduce ourselves, because I think it's just, we have a handful of non-board members, maybe just.
Yeah, that sounds great. Yeah, Danny's got that slide up. So we put this slide together. Danny put this slide together for us at ASRM, just as a quick reference for anybody who is on today or watches the recording. You might recognize a name and be able to reach out to somebody because you've worked with them in the past, or you know who they are and you feel comfortable reaching out to them. But anyway, we're welcome and happy to talk to anybody, but I'm the chair. I'm Marty Gephardt. I'm at Mississippi Reproductive Medicine in Flowood, Mississippi. And so this is my third year on the board. It's a 5-year term. And in your third year, you become the chair. So that's where I am right now. And I'll turn it over to Patricia.
Yeah, hello, everyone. As Marty mentioned, I'm Patricia Hershberger from the University of Illinois, Chicago, and I'm really, really honored to be a member of the NPG board. I've been a nurse for a while. I started out, as a labor and delivery nurse, had an opportunity to work in a fertility clinic, became a nurse practitioner and did that for a while, fell in love with the patients there, like I'm sure everyone on listening in and participating today has. And then lo and behold, I just started maybe doing a little tiny bit at ASRM, dabbling my foot in maybe this and that. And today I'm on the board. So it's just been a great ride, something I never dreamed about back when I became a nurse. So, so I welcome anybody that has that history, or maybe you were much more savvy than me and started, integrating at ASRM earlier in your career. So if you have any questions about NPG, it's really been wonderful for me. I meet so many fabulous people that are all passionate about helping patients get pregnant and keep them pregnant and what to do once they are pregnant. So that's really been a thrill. Just being able to serve in a different way, besides taking care of patients, sitting in front of me on a clinic table or at a desk. So I'll turn it over with that. Who's next on our list? Our vice chair is Megan Pierce. So Megan.
Hi, everyone. I'm Megan. I am first year on the board. I'm still kind of learning and meeting everyone. I work for ASRM. I'm the nurse educator there. My whole career, I've been working with in women's health, and I've been working with fertility patients for, I think, 13 or 14 years now. So definitely passionate, especially about third-party cases. So yeah, if anyone has any third-party questions, I'm always happy to answer. I think Robin is next.
Thanks, Megan. Hi, I'm Robin Scott, and I'm going to date myself, but I've been a member of ASRM and the NPG from back when it was still the American Fertility Society, so a long, long time. But I still maintain a very strong passion for working with infertility patients. I am a nurse practitioner, and about, maybe 8 years ago, 9, 10-ish, I started my own practice as a nurse practitioner, where I travel around to different parts of the country to infertility practices that need nursing help. And it's been a fascinating ride. So between that and my involvement with ASRM, I feel very, very lucky that I still enjoy this as much as I do. I work with a bunch of wonderful, wonderful women on this board. I feel very, very privileged. So I very much encourage people to get involved with NPG. It's been a great ride. Eleanor.
Yeah, thanks, Robin. So I've been a nurse for over 26 years at this point, and I kind of consider myself an all women's health kind of nurse because I worked in labor and delivery and antepartum, and I have my master's as a women's health NP. Worked in infertility a while ago. At this point, years pass quickly, but my research and scholarship is around fertility and infertility. I'm a professor at Duke University and chair of our women's and children's division. And so I feel so committed to all things women's healthcare. And I've been a member of ASRM for a whole lot of years at this point. And now this is my 5th year on the NPG board. As you can see, I'm the past chair. So I'm in the year 5 of the sequence. And I've loved just really being part of this really diverse group of healthcare professionals. I'm also the SART rep. I think this is my 2nd year, I'm forgetting. And so I'm fortunate that that's like my little golden ticket to continue to work on the NPG. I don't know if Marty knows that, but I'm not going anywhere. So I will continue to show up past October in the meetings as the SART rep. And in SART, I'm on the branding subcommittee, and we're doing quite a lot of work and initiatives to try to brand SART. And I also have been kind of doing some pop-up projects at ASRM. I helped kind of launch the Q-Boost initiative that I think a couple names on here look familiar in terms of working on content for Q-Boost for our members. And then a recent one that I'll just kind of do a little preview of is, soon to come, is we've had a couple of meetings with ASRM leadership about creating a new nurse boot camp, like a very formal program for brand new nurses, brand new REI nurses at centers to be oriented over maybe a 6-month to 12-month period. And we had a lovely brainstorming session. Jen Wood, who's not on this call, but has been, as you can see, she's a DEI chair. She and I are the nurse reps on this. There's a couple of REI physicians and then the ASRM staff who are working on that project. So there's opportunities. I guess my point is there's all these really wonderful opportunities to get involved. You don't have to be on the board to get involved. And we're always just looking for ways that we can enhance offerings and support for professional development for our members. So welcome. And I'll turn it over now to, well, Lauren's not on and Anne had conflict. So I guess Tamara. Yeah.
Oh, I get the end. Thank you, Eleanor. I'm Tamara Tobias. As I mentioned in the beginning, I'm a nurse practitioner at Seattle Reproductive Medicine. I've been a nurse practitioner in infertility for 24 years now. I absolutely love what I get to do. And I'm also our supervisor because now we have 12 nurse practitioners in our practice. So I'm compassionate about the field. I love NPG. I love being able to really educate, and like everybody said, is this group, this NPG, we are looking for volunteers. We are so interested in what you're doing out there. And that's why we are so happy to have Elizabeth present today. If there's anybody else doing any projects, any advanced practitioner, we would love to share your projects with all of us. So that's it. I want to respect everybody's time. And again, thank you. Oh, and we have one more slide that just popped up. Marty, if you want to take it away.
I'm muted. Hold on, I'm unmuted. I'm looking at the slide really quickly. I think we just went over this. Yes, okay. So we have some emails on here. My email and Patricia's email as the chair-elect are here, but of course you can reach out to any of us through the directory, email or chat. Anyway is fine with us. we would love to have more involvement. We would love to hear more projects. This is so interesting to hear what's going on with our nurses who are in school, who are furthering education and doing projects and research. And the more I think we can spread it around so that we can all learn from what everybody's doing, the better off we all are and our patients will be. So just want to let everybody know we appreciate this. And if you would like any more information about the NPG or becoming part of the board, please reach out to us. And hopefully we'll do another one of these soon. Get somebody else's research out there and we can hear about what they're up to. And with that, let's see, Tamara. Oh, it's back on Tamara and your background. I guess with that, we can conclude this webinar.
I think so. This has been really great, really fun to see everybody too.
It's been great. Thank you all for attending, and it's going to be recorded. So there'll be some way to get it on the NPG site, correct?
Yes.
Okay.
Yes,
Awesome.
we'll post it and it'll be, we'll put it on our discussion board.
Great. Well, thank you all for attending. I enjoyed it.
Thank you, Elizabeth.
Thank you,
Thank you so much.
Thank you, Elizabeth.
Bye, Elizabeth. Good job.